Hello and welcome to Scrub In. Today we are talking about anesthesiology and surgical care. It's a hot topic today amongst anesthesiologists, obviously hospital executives, and obviously for any patient who's seeking surgical care. So my name is Leslie Basham. I am the president and CEO of Surgical Directions. And today I am joined by three of our national experts of Dr. Jason Klopotowski, Renee Jenkins, and Supriya Patel. So let's dive right in because this is an important topic. And I want to get your thoughts. And I encourage us just to make this conversational, right? Have a discussion. But I pulled up a stat. So a lot of stipends, the costs for anesthesia are increasing. So they're up more than 40% just since 2020, a huge increase. And hospitals are asking, why? Why is this going up so much? What's the return on investment? So let's just get right to it. Why is this happening? Why all of a sudden is anesthesia cost up so much and hospitals paying so much more for the same or maybe sometimes less anesthesia coverage?
Number one, the labor. We've lost a lot of people in the industry. The programs are requiring more, so it's taking more time to replenish the people that have left the industry. And the big thing is reimbursement. Reimbursement has really changed. And now we're seeing, facilities like ASCs that have never hit subsidies that now have to ask.
Yeah, it's a supply and demand economics math question for me. Reimbursements down, cost of labor is up. It's simple math in the end, but I want to really focus more on the perception in the market from hospital administrators that about the rise in these costs, right? Anesthesia groups at one time, a lot of them were profitable for a long time. A lot of them were cutting even. And now what we're seeing is upwards of 85% of groups are requiring stipends. And really what's catching attention of hospital leadership and the people in the C-suite is not necessarily that there's a stipend. I think everybody knows, or people in healthcare know, that this math equation isn't working out anymore. But it's the sheer increase and the multiples of the stipend that are being asked for that I think are rising. This issue from the mid-levels of management to the top of the C-suite now. It's 100, 200, 300% increases in stipend, along with room closures or the threat of room closures. It's really pushing this to the top of any kind of concerns amongst the C-suite. And I think a lot of it has to do with education of those administrators to understand exactly what's going on in the world of anesthesia, understanding how their ORs work. I think that there's an issue with the groups being proud groups or being risk averse to what stipends mean for them, holding out, stretching their labor to the point of burnout in some places that we see, to try and keep that stipend low, and then all of a sudden reaching a crisis mode and coming back to the hospitals with multiples of the stipends that they asked the year before. That catches anyone's attention and becomes a red flag. The hospitals also, I think, need to be educated and understand how their operations affect the cost of anesthesia. When you have rooms that are running at 40, 50% utilization, that equates to time that the groups have to spend paying their anesthesia providers, but not being compensated for those anesthesia providers. And those deltas in that white space or that unreimbursed time very much impacts the cost that's being seen with regards to anesthesia.
Mm-hmm. And I think, Jason, just to add to that, we're seeing, a lot of groups not able to recruit as many providers as maybe they're used to. And now we're starting to see that influx of locums, right? And that increase in cost because of locums. And I think a lot of hospitals are seeing that, not just from a private group standpoint, but also from an employment standpoint. I think both sides of there is now, because of this demand and supply issue, a need to outsource, whether it's locums or whether it's through a 1099. And that's, I think, more prevalent than it was before.
I'll piggyback on that a little bit. It's not just locums.
Mm-hmm.
it's stretching and burnout of your current workforce. We see all kinds of permutations in variable pay and premium pay. In order to cover these rooms that the hospitals are asking for, they're asking these providers to work 45, 50, 55 hours a week. And the physicians in this market, knowing that locums can be paid so well, knowing that there's all these job opportunities elsewhere, are going back to their group or the hospital if they're employed and saying, I want to be compensated appropriately for this extra work I'm doing. And that's been a change that we've seen over the last 5-10 years of anesthesiologists and anesthetists saying, my time is of value, right? It's not the old school where I'm going to come in and do whatever needed. I want to be paid for that time. And the multiple permutations of that variable pay are really driving a lot of costs up in addition to the locums.
A little bit more about that burnout, right? And the whole reason why this is such an important topic, right, is because it's about surgery and patient care, right? So what should these groups be doing, or what is anesthesiology's role in providing great patient care, safe patient care, and what can groups do to make sure that that's sustained, or hospitals do to make sure that's sustained?
One of the most important things is making sure that, our anesthesia providers are okay. Because, and I think that goes back to, with a lot of the private groups, even with the organizations, making sure that mentally, because, the ones that are still, practicing, they dealt with a lot during COVID. And so making sure that they're okay so that they can take care of the patients. And like Jason mentioned before, is transitioning out of that old school model where we expected that everyone could just work as many hours as there were to work, and really making it okay with people having balanced schedules, allowing people to have flexible schedules. I think that's something that's new, that everyone needs to get on board with, that it is a, deviation from what we did in the past, but I think that will help to make sure that patients can be taken care of because their providers are going to be okay mentally as well.
Leslie, I grew up in an age of anesthesia where your anesthesia group was very good if you were never heard from, right? We took great care of patients. There were minimal patient care issues, and we didn't ask for a lot of stipend, if any, right? That dynamic has changed. And it's almost to a detriment of anesthesiologists and anesthesia groups, but anesthesia's a different beast. You're doing a good job, you're never heard from. And unfortunately, our group in 2018, somewhat related to that mantra, lost our contract to another group. Long story there, don't need to get into it, but I truly believe that part of that was, although we were having great care of patients and great outcomes, just taking care of a patient, induction, emergence, safe exits, recovery, that is the most important thing we do. But if we don't show our value outside of that great patient care with blood bank, ERAS, pharmaceutical management, those are all things that we can make ourselves more visible from the hospital and administration standpoint, add value, and also improve the care of those patients. So there's been a dynamic shift, I believe, related to the increasing stipends, that hospitals, administration, leadership, they aren't just looking for great patient care. They're asking what other value can bring to our patients, first and foremost, but also to the vision, goals, and strategy of the hospital in procedural care.
I think a part of burnout, and this kind of alludes to also, Jason, what you were talking about in terms of the other things outside of just providing that direct patient care, right? And I think a big part of burnout is also your culture. And when and I think this speaks to kind of the hospital side of maybe things that they can do, right, to help improve burnout and mitigate that, is helping to establish a better culture, right, with your anesthesia group. And that means including them in the decision making that directly impacts them, or maybe sometimes indirectly impacts them. And that can be some of the examples that Jason mentioned, right, that they're kind of going to be monitoring and improving. But also, anesthesia is a big part of how efficient your OR runs and how not only safe your patients are, but how they get through the system. And they need to be a big part of that decision making, that because they're directly impacted by it. And I think a good example of that is setting up, a collaborative governance structure that anesthesia is a part of, where they feel like their voice is heard. And if they're facing struggles, or if they think the market is shifting and something needs to be evaluated, or maybe something within patient care needs to be evaluated, they have an avenue to do that.
I completely agree. And I want to expand on that a little bit. Getting back to your original question, based on what I had just said and what Supriya and Renee had said, one big thing we hear in anesthesia right now is availability, right? And the cost related to availability. I want to open up OR 10 till 7 o'clock at night. I may not utilize that all the time. Well, the education of the administrators and the people that pay those stipends is that availability needs to be paid for. We can't stretch our anesthesiologists, our CRNAs, our AAs, our staff to fit that need, even if you don't think you're going to utilize that block till 7 o'clock at a high percentage that would increase reimbursement to those providers. And I want to say availability not only pertains to the patient care, but getting back to the things that I just mentioned, there has to be an acknowledgement and education about the cost of availability to add to the value of your institution outside of direct patient care. And that gets missed a lot in anesthesia. We're asking all these providers to take care of patients, take care of patients, take care of patients. We're also asking them to help us with utilization, help us with ERAS protocol, help us with our regional block program, but they need time for that. They need compensated time for that to help align with the value, strategy, and goals of the hospital. And that connection is broken. And one of the things I really hope to do, and what we strive to do at Surgical Directions, is to help groups communicate that and translate that to administration and vice versa for alignment of those goals outside of the great care that anesthesia providers participate in. And that is one of the biggest disconnects I'm seeing in the market.
That's super interesting. And I liked the point too, Renee, you got to make sure that anesthesiologists are okay, right?
Yeah.
And we've talked a lot about anesthesiologists and anesthesia generally, but what is the role of CRNAs or AAs? How are those impacting the landscape right now?
Yeah, I would say that, they are assisting with helping with that burnout, right? Allowing CRNAs to practice at the top of their skill set allows for, physicians to give more oversight, and then also to lend a helping hand, having CAAs and programs also too allow for being able to stretch the workaround, to allow for people to assist in areas and to help hospitals with being able to provide more when we know that there's a limitation on resources.
There's that conundrum between how far do we go utilizing our CRNAs, and then, and what's safe, right? And I think a lot of provider, or a lot of groups, hospitals are kind of also facing the situation where, yes, you have a care team model, or maybe you want to implement that and you are trying to expand that, right? And I think hospitals sometimes also think that they're going to maybe save some cost there, but it could go in the other direction, right? And I also think that it depends on what areas you're implementing a care team model, and expanding that CRNA, MD, or AA coverage, because that value of let's make sure that our quality and patient safety is still there, I think is something that everybody has to come together and agree upon.
The calculus sometimes becomes complex with private groups who have anesthesiologists and employed anesthetists, CRNAs, AAs. There's a lot of different versions of that. And what we see sometimes are financial reasons drive scope of practice. And that's okay. We understand that. However, that being said, there are a lot of different models of safe and effective anesthesia care. We see everything from solo practice to CRNA independent practice and everything in between direction and supervision. We get it. A lot of places do it. They do it safely. One thing that keeps popping up to us in the market, or to me in particular, is there's work out there for everybody right now. There's too much work out there for anybody. And if we don't approach this in an aligned way as anesthesia providers, forget the MD, the nursing, what makes sense for your group has to be something we talk about. And it can't just be, this is the way we've always done it. There's too much work. There's too many expectations. The cost is too high, and the burnout's a real thing. People are getting out of anesthesia left and right because it's just a tough place to be right now. But if we don't have these conversations about scope of practice, what are our optimal ratios in this facility? What is the acuity of these patients? What kind of cases are we doing? Have those conversations, and most importantly, aligning with the hospitals that we cover, or the systems we cover, on a case-by-case basis. It's going to continue to cause rift, continue to cause burnout, and in a lot of instances, continue to increase the financial demands of the department.
I love that. I can see
I
that.
agree,
Like,
Jason.
we need to talk about anesthesia, right? We need to talk
Yeah.
about it, right?
Yeah.
It's a problem in some instances on how, I think, we brought up the point about burnout. 60% of anesthesiologists under the age of 45 are considering reducing their hours or leaving the profession because of burnout, right? And so then it creates this cost dynamic, because how do you keep them? And then we've created something just since last year, since 2024, hospitals spent $2.5 billion on anesthesia subsidies, $2.5 billion on anesthesia. And so we're in this conundrum, right? So how do we create an environment where great care can be delivered and well-being can be maintained for our anesthesia providers?
That's where we come in. I mean, from the hospital, like, every facility is not the same. Every group is not the same. So I think that's where we have an advantage, because we've all played several roles, and we can go in and say, yes, a care team model may be appropriate here. No, an all physician or an all CRNA model may be appropriate here. Or no, you should utilize all AAs, CRNAs, and physicians. But I think it's looking at it on a site-by-site basis and creating that bridge between the group and the hospital to understand why it can work, or maybe why it cannot work. But I think that's one of the advantages that, we do here every day.
And I was going to say, it's interesting, Leslie, you say that, because we've seen with many of the hospitals we've been at that, maybe, and Jason, you probably can speak to this better than I can, but there was a point where a weekly average for anesthesiology or anesthesia work hours was 50 for an MD anesthesiologist. And now you're kind of seeing that shift to 45, somewhere around that area. For APPs or CRNAs, it's 40. So the number of hours that you're working in a week are kind of decreasing from what it was before. And that means that your number of FTEs that are needed are going to naturally increase, because the number of work hours are going to decrease. And that, I think is also something that's a conversation with hospital leadership and the providers, because it's moving towards that, let's keep work-life balance, let's reduce the burnout, and let's see how we can, mitigate some of these things with the number of hours that are worked as well.
I couldn't agree more with that. We're with a client who's doing a large transition to employment right now. And I just want to echo what Supriya said. And part of that decreasing work hours that are expected as a means to recruit appropriately have direct impacts on how we schedule. And it may be night shifts. It could be totally shift work, like we did for a large group in California. And some of these things are necessary from a pure recruitment and let's get our ORs covered standpoint. And it's been a shift in that market. Now, unfortunately, a lot of times it's too late that a hospital's already decided to go to employment that some of these things change. I see some stagnation within private groups, large, national, regional, local, that it's kind of, this is the way we've always done it. And it's very hard for those groups to somehow change the dynamics of how we schedule, how we do the work. This is the way we're always done it. This is the only way we know how. One of the things that we get really excited about is how can we help work with groups to help them educate them on what are alternatives that we're seeing in the market. What can make you more sustainable from burnout? But most importantly to me is how can we help you educate your administrators in the hospital that you provide services for of what that cost actually is. You know, we get a lot of calls that I want to switch to employment because that'll be my silver bullet for the costs that I'm seeing. It's not. It costs, the costs are there. Hospitals get worried about covering their ORs and sustainability and stability. How can groups deal with the burnout that we're talking about in this call, schedule appropriately, recruit appropriately, mitigate their locums costs, and help the hospital understand what that means, not only for patient care, but we talked about adding value in alignment with goals, but being transparent, being strategic, and having a plan of how we interact with the hospital so that both sides have walked out of the room after a sometimes tense negotiation feeling like their needs have been met and they had a fair discussion.
Great point. What you're really getting at is like what creates a relationship between the anesthesia group and the hospital or the ASC that really thrives, right? We've seen unionization in anesthesia. We've seen the opposite side, right? Which is not as positive. So one thing, you know, we've worked in over 100 hospitals, over 500 hospitals, but hundreds of hospitals on anesthesia. What are those kind of important morsels or tips that we can provide of this is a common thread of a highly functioning relationship versus a dysfunctional relationship? Jason, I'll start with you.
There's a lot of answers to that question. I think there's a lot of minutia and in the weeds we can get into. I think the number one thing, and if I could do one thing, it would be covering the ORs. In this time of upheaval financially, you know, in this world right now, the revenue from procedural care in the OR or outside the OR is vitally important. A lot of groups reach these breaking stages and it's, we're gonna not cover your ORs. We're gonna decrease our capacity. We're gonna close your ORs. That is the number one thing that gets raised to the highest levels in the administration. And I'm not saying that there's not
in a good way.
Right. I'm not saying that doesn't come about after many different factors, but the one biggest value groups have, one of them is just being able to cover the ORs in an agreed upon fashion with the administration to keep access to procedural care stable. And that is a complex thing I just said. And there's lots of layers to that and good and bad on both sides. But what we've seen is when restriction to procedural care starts happening, the perceived value of a group drops exponentially.
And I love how you said like that one thing, like what is the one thing? So I'm going to go to Renee and Supriya to have you guys think about your one thing while I ask one follow-up question for Jason. Jason, you said that, you know, closing down an OR is the thing that gets hospitals saying, we got to switch groups. We can't have control over this, or we can't lose control over this. What can a hospital do to help in that situation with the OR? You mentioned something about it before, but like, what's the sort of the hospital's obligation on that side too?
I sometimes think that hospitals don't do their due diligence in vetting the requests from proceduralists, both in the OR and outside of the OR, for additional space. Everybody wants anesthesia. Everybody wants access to anesthesia. What they don't often have is the cases to sustain anesthesia providers. I'm going to pick on cardiology just because it comes up a lot, and this is no offense to any of the cardiologists that may listen to this. Cardiologists are classic in the anesthesia space for wanting an anesthesia provider available all day for their cardioversion or echocardiogram around lunchtime. That's extreme, but I'm using an extreme example here. And what they do is they go to their director, they go to their COO, sometimes they go to their COO and say, I'm going to bring you X amount of volume because I need an anesthesia. And if I have an anesthesiologist, I can bring you that volume. I'm not saying it always works out like this, but oftentimes they are very rarely fulfilling what they've promised because they know if they can tell a COO that I'm going to bring you more volume, that gets clicked, and we are going to the group and saying, we need an extra anesthesiologist. We don't really care how you get it. We need it. And I think vetting that request, and I used an extreme example and I picked on one group, but that happens in every department within procedural care, surgery or non-surgery. And what ends up happening is you get a lot of unproductive time from very costly resources that end up squeezing the group, causing retention issues, causing financial issues, causing burnout, and increasing that stipend to the 1 to 2 to 3 times that we've talked about earlier that are now becoming burning platforms for hospitals and creating this chaos that we're seeing right now. So you don't always need an anesthesiologist when a proceduralist says, I need an anesthesiologist for the day. You may need part of that, but making those demands on a group for unproductive time is frankly unfair to the group, and you'll end up eating that cost in one way or another over the long run.
Thanks, Jason. All right, let's go back to our kind of magic wand, one thing that helps relationship thrive between a healthcare facility and their anesthesia group. So Priya, I'll go to you if you want to go
Sure.
next.
So I would say communication, and I cannot stress enough how important that is to have a thriving environment between anesthesia and hospital leadership. And there's many avenues to that, I think. There's communication when it comes to within a governance structure format. There is, communication when it comes to talking about compensation, talking about recruitment. But I think at the bottom line, anesthesia providers want to know what's going on. And they want to know, okay, we have a plan of action in place to fix some of the things that are going on. And when that is broken, you start to then break trust. And that's when things kind of start going downhill, right? And hospitals then come to a situation where they have to think of other avenues. The anesthesia group has to think of what they're going to do next, right? So that's actually what we spend most of our time on as well with hospitals and anesthesia groups, is just finding that communication bridge between the two and kind of going back and forth with, hey, you both are saying the same thing. You both want the same thing. Let's just come to an agreement on what that plan is and how to get there, right? So I think that's the most important to a thriving environment.
Yeah.
And Renee, so we've heard coverage of the ORs, communication. What's your tip?
I would say be a partner versus a vendor. I think that's very important because with that, I think that kind of rounds up with everyone said, right? When you are a partner, it's that transparent communication for good and bad. Don't just show up when it's bad. Don't just show up when things are rosy. Have that constant communication as far as being a partner, being vested, because you're going to hear about all of the things from corporate, from administration to your leaders on site. I think that's really one of the things that I've seen groups that thrive with hospitals. They have that partnership mentality.
I love that, partnership versus vendor. What is the cost of not doing these things for either the group or the hospital? What is the cost of not doing these?
I would say the biggest thing that we don't think about is that I know we look at the money, but it's really your community, right? The patients.
Right.
I think people not being able to get the procedures that they need because we can't agree. I mean, the obvious thing is that, you may have to switch over to another group, but I really think the biggest thing in all of this when we can't provide the number of staff or when the hospital can't provide the support, it's the community that suffers.
I was going to take, Renee took mine. One negative consequence that we're seeing is the inability for groups to survive. And I think private practice and third-party anesthesia groups, I think they have a place in this world of anesthesia within our country. We've seen that when there's not great communication, there's not great partnership, some of those groups don't survive. And I think the way that it was approached with their relationship with the hospital, there's mistakes. I don't want to be a Monday morning quarterback, but a plan, a strategy to how your group's going to survive, provide value, and be a good partner to a hospital. I think being proactive with that can lessen the risk of that happening to groups. I don't want to not mention Renee's point. I want to piggyback on that. Ultimately, it's about patient care in the community and access to procedural care that people need in every part of the United States. And I think that really does suffer when we have two silos that are mad at each other, who are, working on propaganda campaigns or whatever message they're sending in the community amongst themselves to their physicians. The hospital won't work with us. The hospital's being stubborn. The group's being stubborn. Sometimes I just want to lock these people in a room together, right? The administration and the anesthesiologist, and say, let's hash this out. Everybody means very well. We work a lot with hospitals, and very few of them have any nefarious things to say about anesthesia. They actually know they have to pay for anesthesia. They know they have to get along with anesthesia. They don't know always how to get there. And we see groups the same way that have become so entrenched and angry at the hospital because, frankly, sometimes they just don't understand or have the education to understand what's really pushing them to where they need to be. That just communication breaks down, alignment breaks down, and there's just distrust on both sides.
I would, and I think Renee also, so what I was going to say too, I think, serving the community is the most important, and that's the cost that comes into play here. Along with that, I do think that many places we go to, the anesthesia providers have a good relationship with their surgeons they work with, the staff they work with, and a cost is, other people being impacted by this, right? And surgeons then feeling that limited access, that pressure, their relationships getting strained, staff being worried about their jobs, right? Because anesthesia is the crucial key to everything running, right? And that has a ripple effect to everything else and everybody around it as well. So I think that's another cost.
I think that's a great point. How often do we see, Supriya and Renee, recruitment and retention of surgeons and their ability to operate in small or large communities, and how much anesthesia plays a risk in losing some of those providers that people spend a lot of time recruiting to that organization.
Right.
Yeah. Supriya, you brought up a good point, because it's the employees of these groups too. It's the physicians, CRNAs, AAs that are impacted, that they want to work there, but they're caught in the middle like children in a divorce that we sometimes forget about, right? So,
right.
Very important point.
Well, thank you all so much. 3 of our national experts on anesthesiology. I'll do a lightning round. So based on everything we've talked about, is there anything that we haven't touched on or that you want to double click into before we wrap up?
Don't be afraid of change.
Yes.
And don't be afraid of being proactive about the cost of your anesthesia services. Everybody knows anesthesia costs money. Everybody wants a sustainable practice. Hospitals and administrators know they need to spend money. They want to do it in a way that's transparent, fair, and aligned with their goals. I couldn't say that enough, or with enough emphasis. That is really the key. And if you don't know how to do it, find someone that can help you in that road to make yourself as valuable as possible and education on that value along the journey.
And I would also say, evaluate your options, right? An option that you may think is the right thing may not be. And you know, I think everything is on the table, whether it's employment, whether it's a contract negotiation. You know, I think there is never a truly right answer. You have to weigh everything on the table.
Well, thank you all. This was very enlightening. I always learn a lot, and hopefully through this conversation, our listeners can as well. And I loved the point about it really comes down to our communities and our clinician well-being, and how do we make sure that we provide safe and accessible surgical care for anyone who needs it. So I appreciate everyone's time, and that's a wrap.